Hello, I am Dr. Subhashis, consultant cardiologist at Narayana Health, Barashat. Today, I will be discussing with you the management of hypertension in diabetes patient, the RSSDI recommendations. Now we know that hypertension and diabetes are two of the leading lifestyle diseases in Indian and South Asian population that often coexist due to overlapping pathophysiological factors like obesity, insulin resistance, inflammation, and oxidative stress. And these are thought to be some of the common pathways. Up to 50% of the hypertensive cases in India are diagnosed with type 2 diabetes mellitus. The recent RSSDI guideline provide a comprehensive recommendation for the management of hypertension in patients with diabetes. Number one, as per the Indian guideline of hypertension 4, hypertension is defined as systolic blood pressure of more than 140 millimeter of mercury and or diastolic blood pressure of more than equal to 90 millimeter of mercury. Now, primary hypertension is the mostly asymptomatic, and while secondary hypertension is due to various underlying pathophysiologies, uncontrolled blood pressure, despite usage of 3 antihypertensive drugs, is referred to as resistant hypertension. Over 1 billion people suffer from hypertension globally, which is expected to rise to about 1.5 billion by 2025. And up to 50% of cases of hypertension are also diagnosed with type 2 diabetes mellitus. Hypertension is a major risk factor for heart failure, cardiovascular diseases, chronic kidney diseases, peripheral artery diseases, erectile dysfunction, and end organ damage. There is a complex cause-effect relationship between hypertension and diabetes, which predisposes the patient to increased risk of cardiovascular complications. For patients with diabetes and hypertension, a 24-hour ambulatory blood pressure monitoring is recommended, and it is recommended to maintain a blood pressure target of 120 to 130 in this ambulatory blood pressure monitoring. The use of aneroid sphygmomanometer must be preferred over digital devices. However, digital machines may be preferred for home-based measurement. Blood pressure thresholds vary with age and comorbidity. So it is not that 140/90 is for all. It varies according to the age and comorbidity. Regarding the management, first comes the non-pharmacological management of hypertension in diabetic patient. First is the lifestyle modification, and this may delay the need for pharmacological intervention or can complement blood pressure lowering effect of the drugs. The non-pharmacological managements include a low sodium diet, good physical activity, at least 30 minutes per day, a healthy diet, and all this can be used to manage hypertension in a patients with diabetic patients. Now coming to the pharmacological management of hypertension in diabetic patient, the most important drugs are the angiotensin receptor blockers or the ARBs. ARBs are recommended as a choice of therapy, preferably in combination with calcium channel blockers, and to manage hypertension and its complication. For combination therapy, newer calcium channel blockers like cilnidipine along with ARBs are recommended. Cilnidipine is a novel, effective, and safe calcium channel blocker, which is established for its renoprotective benefit. Combination therapy of angiotensin receptor blocker with thiazide-like diuretics also reduces the risk of renal disorder. While telmisartan can be a first-line ARB for diabetic patient due to its beneficial effect in fasting blood glucose, insulin levels, but azilsartan with a similar safety and efficacy can also be recommended. Thiazide-like diuretics can be preferred in elderly patient and with existing cardiovascular diseases. ACEi inhibitor, that is angiotensin converting enzyme inhibitors, these may be used as an alternative to angiotensin receptor blocker for cardiovascular disease risk reduction in high-risk patients. Beta blockers may be preferred in patients with previous history of cardiovascular disease and as an alternative to RAS blocker in pregnant women. So now to summarize, hypertension is a strong and modifiable risk factor for the macrovascular and the microvascular complications of diabetes. There are strong evidences from clinical trials and meta-analyses that supports targeting blood pressure reduction to at least 140/90 millimeter of mercury in most adults with diabetes. Lower blood pressure targets may be beneficial for selected patients with high cardiovascular risk if they can be achieved without any undue burden, and such lower targets may be considered on an individual basis. In addition to lifestyle modification, multiple medication classes are often needed to attain the blood pressure goals. Thank you for your patient hearing.